So good afternoon, everyone. Without any delay, we'll start now. So welcome to the session of Optical Coherence Tomography and Artificial Intelligence in Glaucoma. So first, we'd call on the first speaker, who is Sudipto Bhatta, application of artificial intelligence in glaucoma. So I'd like to welcome Dr. Sanjay Asrani, sir, and Dr. Sagrika Patyal, ma'am, with me, Dr. Ghazala, as the chairpersons. So we can start.
Good afternoon, delegates. First of all, very big thank you to the AIOS committee for inviting me and giving me the opportunity to speak today. And a special thanks goes out to Dr. Namrata for inviting me as well as the chairman of the scientific committee. I am from Calcutta. It's very nice to come back home and deliver this talk along with some other esteemed guest speakers. So without much ado, so application of artificial intelligence. This is really interesting because I learned a lot while making this presentation. So this is where I work. I come from United Kingdom and I work in Aberdeen in Scotland, and that's my hospital. So going into the topic itself, artificial intelligence first develops its roots in the Dartmouth summit in the 1950s, when there was this concept of development of computer systems being able to perform tasks that normally a human brain would do. And things like visual perception, translation between languages, which we actually see in our everyday life nowadays. We ask Alexa to do something, or Siri, and it does it for you. They tell us what the weather is going to be, and so on and so forth. The chat GPT, many of us in this room might be aware of it. So things like these are gradually entering our everyday life, and also in the field of health sciences and in ophthalmology in particular. This is a fun slide just for a concept what AI can do nowadays. So the top picture is no other than the famous painter, Vincent van Gogh, which we all know, created by AI. The bottom left is a robot, Kismet. Many of us might know this. He was very popular in 1990s, and it was meant to mimic human emotions. And I was recently at the American Academy meeting in California, where I saw cabs without a driver, the Waymo. So these are the applications of AI in our everyday life, and they are indeed very helpful if used intelligently and usefully. Some basic concepts about artificial intelligence, what it is, because it's a relative new concept. So it's a problem-solving exercise for softwares that mimics the cognitive functions of learning, and the machines process and recognize patterns from large data sets and make up a model, which normally a human brain would do and give us a result. In ophthalmology, we are unique because we're technology-based, imaging-based, and there's enough scope for the application of AI in ophthalmology, which we'll see in the next few slides. I don't want to bore you with definitions, but these are essential ground rules of AI, and I'll keep it very simple. For me, it was, like I said, a steep learning curve for myself to learn AI. So deep learning is a class of machine learning algorithms, and it's a computation to the artificial neural networks, or processing and learning from large amounts of data, which uses neural networks, which is nothing but a computer system modeled of the human brain and the nervous system. All together, a network of neurons communicate with each other and outputs the data. And machine learning takes in both of these into account, and it's the capacity of the computer to learn from trial and error and formulates a perfect model. And this is the pictorial representation. So we have got deep learning on the left and neural networks on the right. Together, they form a machine learning from large amount of data sets. Just for example, lots and lots of fundus photos. And they learn from trial and error, which is normal, which is abnormal. And they create an algorithm, and in turn creates a model. And that is artificial intelligence all under one umbrella. In ophthalmology, we'll talk about glaucoma in the next few slides, but it has its application in other specialties as well. For example, detection and gradation of cataracts. In medical retina, it has a special role, which is coming up very fast and quick, is to stage diabetic eye disease, for example, or to stage retinopathy or prematurity. And in cancers, it can classify choroidal melanomas and see how the outcomes are, or in reconstructive surgeries for basal cell carcinomas. So there's a lot of evidence out there in the literature. The top one is artificial intelligence algorithms to detect glaucoma and detect the progression and diagnose glaucoma. The bottom one was done between the Imperial College London and the Singapore National Eye Institute. That's a very recent article which I found very, very useful. If you're interested, you can go back and look at that. It's a very interesting read. It compared 3 specialties: respiratory diseases, ophthalmology, and breast cancer. And we stood at par with the other specialties to see how important and how useful AI can be in the field of ophthalmology and in glaucoma in particular. Some terminologies, again, not to bore you too much. We all know what on the right-hand side, the 3 definitions are. Accuracy means how accurate a model is in terms of prediction. Specificity is the capacity of the model to detect the true negatives, and sensitivity is the true positive. And anything above 90% is regarded as a highly accurate model or an algorithm. The interesting one is on the left, which I learned myself. It's the AIOC, or the area under the receiver operating curve values. And if it's more than 0.7 up to 1 is the max, then a model is regarded as highly accurate. And we'll come to that in the next few slides. I'm sure few of us, or most of us, know what this picture is about. This is a triggerfish, which has got 2 fins on the dorsum. The back fin triggers the erection of the front spiky fin when there's a threat of a predator. And that's what has been employed in the triggerfish, which we use in glaucoma world. As we all know, the corneal strain gauge on the contact lens, and that triggers off and senses ocular volume changes, and in turn, intraocular pressure changes. And it's got a definite role where AI comes into play in measurements of intraocular pressures. So there has been triggerfish data with meta-analysis to identify parameters that are important to understand the underlying disease process. For example, in normal tension glaucoma, what actually makes the changes happen. And it's got a place, as you can see here, this is the NICE, which is the watchdog of healthcare in the UK, and the triggerfish data has got a place in it. So these things are evolving gradually. Every few years, there's a new development, and these have got a definite role to play in the future. The next few slides will be in the structural and functional evaluation by the AI and how we can put that in everyday practice. So we've got the optic disc evaluation. These are the 3 major studies that I picked up on. The Lee et al. Showed more than 95% specificity and sensitivity to pick up glaucomatous optic discs compared to normal ones. The Pegasus is a similar model designed at the Al Aswad, does the same thing. Has been found more than 5 out of 6 times. It's better than a practicing ophthalmologist to detect glaucomatous discs. And the last but not the least is the RIA-G, which is an Indian company, the Calf Innovations, which designed, again, from cup disc size, NRR, CDR ratios, and it can have a very high AIOC value, which means very high accuracy of the model to detect pathological glaucomatous optic discs. This is a very busy slide. I don't expect you to read through all of it, but I just want to attract your attention. So it keeps on saying the same thing. So the vertical cup disc ratio more than 0.9, RNFL defects, visual field defects, all of them together makes the model more robust and helps a more accurate prediction if the person or if the disc is glaucomatous or if it's normal. Which means we just move on to the next bit, which is the structural evaluation by the OCT. And segmentation, that's another keyword in AI. So super segmentation and deep learning of the OCT images, which are tens and thousands of images, will in turn help to spot which is normal and which is abnormal. And they all combine in together in the weaving of the same kind of endpoint, creating that ideal model where we want to see if the disc is pathological or not. And if you combine it with the functional aspect, which is the visual field study, so lots of visual fields, the pattern of glaucomatous patterns are detected, and in turn, the machine will tell us exactly how it's going ahead. And that's the evolution. On the top, you can see a glaucoma specialist feeding into a machine and creating abnormal and normal diagnosis. And the bottom one is the deep learning, the end-to-end deep learning model, where you just feed in all the data, and it comes out as, without the help of any ophthalmologist, it comes out as abnormal or normal. And that's the theoretical workflow, where on the top, the primary care provider, which are optometrists, they can gather all the 3 data that are in question, feed it into the machine will tell at least These are not glaucomatous discs, and they can be discharged in the community. That keeps the workload in the hospitals, in the secondary cares, to a minimum, and deploy the actual potential to treat patients who have got the pathology. And there are immense possibilities, as you can see here. I don't want to read out all of them, but from early diagnosis to research and development, it can be used in several ways to our advantage, AI. It has got its pitfalls because glaucoma is such a condition which is multifactorial, age, gender, sex, and different parts of the world varies from one part of the world to other. So a perfect model is yet to be created. However, we are not far away. So standardization algorithms, clinical validation, and regulatory approval are necessary. And this is the summary. So we can use AI to our advantage to create the perfect model. And once it has passed the regulatory approval in different parts of the world, we can create the perfect setting where we can just flash a smartphone and say, at least, this disc is not glaucomatous, you can go home, or please go to the hospital. Friend or foe, time will tell. And this is my final slide. So on the left, we had an AI summit of the world headed by the United Kingdom. And on the right is my departmental colleagues and members of the glaucoma team whom I work with in the Aberdeen Royal Infirmary. Thank you.
Thank you so much. So yes, there may come a day when AI will maybe help us to diagnose glaucoma all in all, but as we all know, it requires a lot of factors, intraocular pressure, optic disc, visual field. So we have to develop algorithms for all of them connectively. And also we have in countries like South Asia, Southeast Asia, where angle closure is very common. So that's another thing we have to consider, maybe AIOC-based diagnosis for angle closure, because some of them may have normal discs and they may need some sort of treatment. Any questions from the audience?
Next, thank you very much. That was very enlightening that there may be less work for glaucoma specialists, but more focused work for glaucoma specialists in the future. May I please invite Dr. Deepak Edward to come and give us a talk on an update on visual fields in glaucoma. Dr. Deepak Edward, I know since the last 32 years, when I first went to University of Illinois at Chicago, and he was a professor there, and he is professor of ophthalmology and ophthalmic pathology at University of Illinois at Chicago. Dr. Deepak Edward.
Thank you very much for this invitation to the scientific committee and Sanjay for introducing me. So I'm going to speak on a relatively dry topic of visual fields. It usually puts people to sleep. But I'll try to give you some updates, and some may not be completely new, but I think they're kind of important to recognize as you practice glaucoma. So we'll talk a little bit about the different types of testing modes that are available now, role of central visual field testing, testing of patients who have poor vision, and also the categories of types of visual field progression you have in glaucoma and how you measure them using new algorithms. So just to remind you and also remind myself that most of the action when it comes to retinal ganglion cells, so they're really located in the papillomacular bundle. And so testing of the sort of central 24 degrees of field becomes an important aspect of functional testing for glaucoma. So this is the field test. We are most of us are used to testing patients, the CETA standard Humphrey visual field on the Zeiss machines. Of course, I'm not going to talk about the Octopus machine. What we have new on the Humphrey visual field analyzer type 3 is the CETA faster test, which is the main thing is the timing is shorter, about 2 minutes for each eye. And this test time reduction is largest in eyes with severe field loss. It turns off the false negatives and blind spot, and therefore it saves time. And there are several studies suggesting that the CETA fast is equivalent to CETA fast and has comparable results. And However, when you have moderate to severe glaucoma, it may conceal progression. So that's one of the drawbacks of this testing. Switching over to CETA faster does not require a new baseline. And the Humphrey guided progression analysis, which I'll briefly touch upon, has been updated to allow free intermixing of the data of all three CETA testing algorithms in the same analysis. There's another new component to the CETA faster. You have the 24-2C2 test, 2C test, which adds 10 additional points for testing in the central visual field, the nasal part of the field, as depicted as you see in the black boxes in the lower half of the screen. And the time testing is less than CETA fast. So you get this additional paracentral test points so that you're able to look for these paracentral points, and we'll talk about the importance of that in just a second. Here is a patient who, on the left, had a standard 24-2 test, and the one on the right shows you a 24-2C2 detecting additional paracentral scotomas in this particular patient. So why is this important? Why do you want more information about paracentral scotomas? In the last several years, we know that people who have these scotomas have a poorer quality of vision, a quality of life. They do have interference in reading. Recent paper shows that these people have poor stereopsis as well, those who have these paracentral scotomas. And I've noticed that most patients don't express it even though they see it or they feel it. They won't tell you. I have a physician patient who is really annoyed by this scotoma when he plays golf. He has a dense paracentral scotoma, and he says the ball just disappears in the flight path. And he's very annoyed by it, but he's learned how to avoid that scotoma by shifting his head. So these paracentral scotomas, often are nicely depicted on the OCT, where it is you might have a normal RNFL, but you will see retinal ganglion cell loss in these patients when you do the GCC thickness. So that's a nice way to confirm that these spots are real by comparing it to an OCT. Now, there's been a lot of talk about, that a lot of patients do have paracentral scotomas, and that 10-2 visual fields should be a part of the testing for every patient. But, it's a longer test, and it doesn't have the CETA algorithm. Patients don't particularly like taking the 10-2 size 3 test. And so there's a very nice review paper that came out recently, last month, and this is in ophthalmology. And basically, the conclusion of the paper was that evidence to date does not support routine testing of 10-2 in patients with early glaucoma. But if you do have those repeated visual field defects on a normal field in the central locations, 12 locations of the standard 24-2, or those who have inner retinal thinning on OCT scans of the macula, those patients might benefit by getting additional 10-2 visual field tests. So I think I find this slide kind of important, and this is work actually that was first pointed out by Dr. Chauhan in Canada, but basically classifying different types of visual field progression. And that is a normal patient who's had number of fields. The progression should be 0 to about 0.5 decibels. Those who have more than a decibel loss in mean deviation over a period these are fast progressors, and I think those are the ones that need attention. And a third category of someone who loses more than 2 decibels per year over a number of exams was termed as catastrophic progression. So what are the risk factors for fast or catastrophic progression of glaucomatous visual field? As you might expect, you know this from before: old age, peak IOP, myopia, soda exfoliation, and baseline mean deviation being large, and not IOP fluctuation. It does not seem to be a progression factor. And a paper from New Delhi also pointed out that patients with POAG, PACG, and juvenile glaucoma have similar median progression rates. So how many fast or slow progressors or catastrophic progressors are there in a practice? So if you were in a Private practice general ophthalmology setting, you might have less than 10% of patients of glaucoma that you take care of will have fast progressors, and 30% maybe slow progressor. This number seems to be much higher in glaucoma practices, and about 30% has been reported in some glaucoma practices. So switching gears a little bit, and sometimes you see fields like this where you have a marked depression of the visual field, and this really is not of much use on a 24-2. So you really need to change the target size or the visual field type. So someone like this with 20/20 vision on a central island does much better with a 10-2 size 3 field, and you get much more information. But the thing to remember is, again, these tests take up to 5 to 6 minutes per eye in order for a patient to complete it. Again, patients who have good central vision, the 10-2 field is really good. Those with poor vision, you probably want to use the size 5 target, and you get these quad totals, which are depicted at the bottom slide. These are useful in following those patients. Now, how do you measure progression using the visual field? So again, this is kind of important because field defects appear later in glaucoma when you lose about 40 to 50% of your ganglion cells. And but fields, on the other hand, have lots of variability from the patient, the machine provider, and other errors. And you can do this by clinical judgment, event-based analysis, or by trend-based analysis. So the clinical way is if you don't have, most of the machines, the type 3 Humphrey analyzers have these built in. But one good way is to just, if you have all the fields available on your EMR or your paper records, changes can be small. So I think it's really important to look at the first visual field in your record at least once a year, because you may not be able to detect small changes from the previous field, but if you go back and look at the first field, sometimes you'll be horrified that under your own care, people have progressed and that this was missed. You can look at mean deviation, pattern deviation changes, and whether the changes are focal or diffuse. And also really important to remember that visual fields do fluctuate, and you need to repeat if there's any question to make sure. The GPA, or guided progression analysis, has somewhat made life a little simpler, where you need a few fields before you can use this, and the testing location is followed up and evaluated relative to the baseline, and change is flagged if there is greater than 95% significance level. And this is tested against a large group of cohort of stable glaucoma patients who are tested over a short time, and that's built into the machine. And GPA accounts for some increased variability found in advancing disease. So you can get an event-based analysis where basically what it's doing is change from baseline. So it compares the pattern standard deviation with an average threshold values at 2 baseline studies, and it tells you whether this is worse or not, but it's not a good test to apply when you have very severe glaucoma, and the printout gives you the answer. Trend-based analysis is more linear regression model, and it shows you how the field progresses based on mean deviation of VFI, and you get a graph like the one you see at the bottom, and it shows you the progression of how the progression goes, and it actually gives you the mean decibel value of change at the bottom, which I'm not sure is very clear there on that picture, but that gives you the rate, so you can tell the patient is stable or not stable. So the reasoning behind this was this testing between 2 baseline values. So if more than 3 points change and 2 consecutive change, it was labeled as probable. The machine will tag it for you. And if there's more than 3 consecutive follow-ups, it labels as likely progression, and all data is derived from the early manifest glaucoma trial. The Zeiss Forum, an expensive piece of software which can house a lot of this data, both the images, OCT, as well as the visual field machine data, can give you a very nice summary of everything that has happened in the visual field history of your patient. You can change the baseline if the patient's had surgery. You can discard anomalous testing, which was which you thought was unreliable. And like I said, you can identify specific or annotate specific laser and surgery areas. So you can get a very nice plot like this, as you see in this picture here. So this is a busy slide, but it still tells you that basically compared to an expert review, whether you're looking at it by visual field or by optic disc parametry, an expert really did better than the GPA, so you have to take it with a pinch of salt, the GPA analysis. So again, this was the critique that this was too wide. And actually, this is the last slide, and I'd like to thank you for your attention. One point I didn't bring up, and maybe if there's time for discussion about virtual field analyzers, I didn't put that in my talk. I have limited experience on that. Thank you.
Yeah, thank you, Dr. Deepak, for giving us an overview of what is there latest in the perimetry. Now, if we get time at the end, we will have discussion at the end, question answer. So next, I'm going to invite Professor Steven Mintzberger, who is the professor and chair in University of Portland, Oregon. He is going to talk about how to use OCT in the glaucoma in clinical management.
Good evening. It's great to be here. Thank you to the organizers for inviting me. So I thought I'd try to give you some practical ways of using OCT in your clinic for helping to manage your glaucoma patients. These are my disclosures. We do receive some equipment from Heidelberg for some of our research. So first of all, I just want to go over the importance of structure with glaucoma. And when OCT is not accurate, this is going to dovetail, I think, to Dr. Azrani's talk a little bit later. When not to use OCT, when you're just wasting time, and which modality do I typically use? So this is just some longitudinal clinical studies that look at the rate of progression of our glaucoma patients. You can see here that a large proportion of our patients are getting worse over time. And it just kind of shows to us that, if you're not detecting glaucoma progression, let's say between 10 and 35 or 60% of your patients, you're probably missing a fair number of patients that are progressing in your clinic. And the probability of blindness over a long period of time is pretty high. In the Olmsted study, which is based in Mayo in Minnesota, the probability of blindness in 20 years was 27% in one eye and 9% in both eyes. And of those just initially treated for just ocular hypertension, it was 14% in one eye and 4% in both eyes. So even patients that don't have any optic nerve damage, but just elevated pressure, can go blind. This slide comes from the ocular hypertension treatment study, which showed that of those that develop glaucoma, more than 50% of them, 57% of them, develop glaucoma just based on structure. So again, the importance of OCT and looking carefully at the optic nerve. So there's lots of different algorithms for using OCT, and I'll just kind of tell you, what I use and why I use them. There's the sectoral scan, which is this imaging on the left, which takes a slice on multiple different quadrants in a clock hour type pattern around the optic nerve. There's a circle scan here that takes a circle image right around the optic nerve to get nerve fiber layer thickness, and then there's the macular scan. So how do these differentiated? The circle scan is probably the most common one that we see in the United States. The highest sensitivity to progression, so changes in OCT retinal nerve fiber layer thickness, it's the highest sensitivity. It's common to all the devices, and the nice thing about it is easy to plot longitudinal or values longitudinally, and there are a little bit differences in measurement technique, but it works pretty well in all the machines. And so this is kind of an example, and the way I explain this to my patients is what this is going to take a thickness measurement around your optic nerve. We're going to unroll that measurement here, and then we're going to compare you to a normative database, and then here is where your data, whether you're normal here, and then outside normal limits here. But this one it can be, and this is something I've been interested in, into segmentation errors, where the machine will mix up where the nerve fiber layer is. And so this is a paper that we published which looked at the auto-segmentation here. You can see this red line, but it had missed this area here. It thought the thickness was too thin here, and so with manual refinement, you can, the thickness actually is increased. And what we found that this auto-segmentation errors occurred in a large proportion of patients with glaucoma. The interesting thing about this was, and Sanjay will probably go over this a little bit more, Dr. Azrani, is that, you know, it occurs, these segmentation errors occur with worse glaucoma. It occurs in areas where the blood vessels are, which are the areas that we detect changes in glaucoma. So it's really an annoying thing, but maybe artificial intelligence will improve this in the future, and we're working on that currently. You see artifacts from vitreous traction. You can see this patient who you might think, you know, if you just looked here at their plot, you think, oh my God, this eye is normal, but you can see this vitreous attaching to their nerve fiber layer and actually making their thickness much thicker than it would be. And then when this releases, it'll seem like their nerve fiber layer thickness became thinner, which is actually just an artifact of the vitreous traction. And then this is something else that we've been very interested in. We've been finding these areas of schisis, and so this is a really patient that I followed her for a long time, probably like 8 years before we got OCT. And then I was really mad because we got the OCT and you could see this schisis was occurring. And it's actually right here. You can't see it when you look at her just with ophthalmoscopy. And it doesn't, you can see a little bit of a hint of it here on the OCT in-FOS image here. But then you can see the schisis here. And it led to a project that we wanted to look at how often the schisis occurred. And, oh wait, I'm going backwards here. And so this is just an example of a patient with schisis in this area here. This is the same one here. It's here too, and then it goes away. So it kind of softens here and then goes away. This is a different patient with a schisis right here. It goes away about 5 months later. So this is another one of gives false positive and false negative results to the OCT. So the point about this is just look at your scans to see if you're seeing these unusual things there. Oh, this is just one other example of where the schisis was occurring in so many different layers. And we published this, I think, at IOVS. But you can see a schisis occurring here in the nerve fiber layer here, and then going away, being totally normal here, and then getting a schisis in 2 different locations, and then going away for the most part. And then I think we had something coming back here. But anyway, we think this schisis is a really interesting thing, and it's part of the pathophysiology of glaucoma. It's just not an artifact. It's part of what's happening with the pulling and tugging with glaucoma. This is some work from Brad Fortune from our group who believes this is Mueller cell dysfunction. The Mueller cells keep the cells together, keeps the retina together, and they become sick or tired, and you get this schisis occur, and then all of a sudden they recover, as you can see in those photos, and they start to keep the retina back together. So, the OCT just doesn't show the nerve fiber layer thinning. There's this dynamic process happening. The other type of scan is a macular scan, and this is the easiest location to segment. It's comparable accuracy to the circle scan as far as progression, but it's inaccurate with coexistent macular disease. So a patient with drusen or epiretinal membranes or anything like that, this testing will not work well. But we think it's best for patients with myopia and with those that have peripapillary atrophy around the optic nerve. We also think this scan may be better for patients with, I already said this for myopia. And the problem with myopia is they get retinal thinning, they get peripapillary atrophy, which give these artifacts. They have the optic nerve tilting, which can give artificially thin nerve fiber layer thickness, and they can also have visual field defects that are completely stable. So this is a paper by one of our fellows, Jinwok Jun, who showed that one area of this with a macular scan, it was the most accurate of determining myopia from myopic glaucoma. This database, and Dr. Azrani did an editorial on this paper too, but this database did exclude patients with drusen. It also used a supernormal myopes, meaning that their optic nerves were used as a criteria for inclusion. So, who knows whether this is really the best way to determine myopia versus glaucoma, and we're also doing some work in this space. And then finally, the sectoral scan. This is something that was popularized by Claude Burgoyne and Bao Chowan. What this does is takes multiple different sectors of the optic nerve, and then you segment the Brooks membrane opening. This Brooks membrane opening creates a minimum rim width, and we think that this is less, we think it's less sensitive to early progression, but we think there's less of a floor effect. So if you have somebody who's gotten a floor effect with the nerve fiber layer, which I'll show in just a second, this might be the best OCT to go to. So all of our instruments for OCT have a floor effect, and what that means is you're going to do this testing, and you're not going to see anything changing on the OCT because the patient is as thin as they're ever going to get based on this, on the OCT. And so it's something about 49 microns with a Heidelberg, up to 64 microns with the OptiView. And this is when you don't need to do an OCT. If they're at the floor, then you don't need to do it. So what do? I typically use the circle scan. It's just simple for my clinic when I'm seeing 50 and 60 patients a day to have the technicians doing the same type of test for every patient. And what I do is I kind of explain this, what I do with the patient, but this is a patient, for example, who's got one eye that looks like it's normal, one eye that's outside normal limits. And then I used an event-based way of determining whether they're progressing, and I use a 10 micron change from baseline versus currently. So what I do when I review my OCTs is I write down whether it's abnormal or normal, what the thickness measurement is, and then what the baseline measurement is. There's also a slope-based measurement, so if they're over 2 microns a year of thinning, that's a sign that they're progressing at a fast rate. And I also adjust these cutoffs. If they're looking thinner by about 5 microns, but it's somebody that's young with a high pressure, then I'm going to be more aggressive about treating them. And then I like to use this longitudinal plot. What you can see here is the original baseline exam, the subsequent exams, and then if you zoom in, you can see that this eye is progressing quite rapidly in several different areas. And if you've done an intervention in between then you might have to have a new baseline. And kind of the same plot here for the left eye. The left eye was progressing too. So my take-home points is without OCT, you are missing at least 50% of your patients with progression. Look for artifacts that create false positive, false negatives, and are part of the definition of glaucoma, we think. Use a standard method of following your glaucoma patients using longitudinal plots. And I think for, future testing will include a full cube scan. They'll just do a whole scan of the back of the eye. And they'll use AI to pick which part of the eye that it's best for this patient. And we won't have to pick between these 3 different scans for OCT. Thank you.
Thank you, sir. That was fantastic, actually. And may I call upon Dr. Sanjay Esrani? I don't think anyone in this hall probably does not know Dr. Sanjay Esrani. We've learned so much from him, through so many years, and we'll continue to learn from him today too. Sanjay Esrani, please, sir.
Thank you, Sagarika. That is a glowing introduction. I don't think I deserve it that much, but thank you. I'm going to be talking about red disease artifacts in OCT, and I think Dr. Mansberger set the stage perfectly for me by explaining how he uses the spectralis OCT in clinic. Now, why do we use the term red disease? Because red indicates alarm for us. Red indicates easy color to spot. That's why the Maasai tribes wear red when they are in the mountains, because you can spot them very easily. So red is always the indicator of danger, and that's why we use red in our normative databases. But then unfortunately, just because some measurements go into the red, it means like as if there is an abnormality, which is not necessarily the case. I'm going to share many examples for you, and it is in this order. That is myopia, machine errors, masqueraders like cancer-associated retinopathy, vascular events, other optic atrophies, neurological causes, age-related, congenital, and capture of OCT before loss of tissue thickness. So when not to do an OCT in patients like this, where your circle scan is not large enough to go outside the area of the peripapillary atrophy. So then the measurements are not easily comparable to a normative database. You can see my mouse here. So it's not that you shouldn't do an OCT in this case, but don't rely on the normative database, but rely on the actual superotemporal and inferotemporal thickness. If that is normal, then very likely that this patient doesn't have glaucoma. The reason is that in myopia, all the nerve fiber layer tissue is more towards the fovea, more temporal. So if especially the temporal area is intact, then there is less likelihood of glaucoma. Of course, in such cases, using the macular thickness map is extremely useful to identify glaucoma or not. Then, of course, there is the machine errors, like what Dr. Mansberger already showed you. You can see here, it looks like that there is progression. But if you carefully look before you assume that there is progression, you realize that the software has missed the lower boundary of the nerve fiber layer. So therefore, it's a missegmentation. Therefore, it looks like it has gotten thin, but it hasn't really. Here is an example that is not easy to identify because you got extreme thinning of the nerve fiber layer. You got severe loss of macular thickness. But if you look at the asymmetry plot, that is this left versus right and right versus left, the thickness difference between the two eyes is most away from the optic disc and in no arcuate pattern. This tells you that this may not be glaucoma. When it is not in an arcuate pattern in the asymmetry, this happens to be cancer-associated retinopathy, where the photoreceptors have died. Therefore, the retinal thickness is low. But that also affects the nerve fiber layer, surprisingly. Here is an example that we don't get to see very often. We see a patient whose nerve fiber layer has thinned out considerably in the superotemporal region. You can see the macular thickness has thinned out here. You see a new field defect. But is it glaucoma? Actually, no. This was because of a cotton wool spot that had been noted by another doctor 6 months ago. So that's why there has been a loss of tissue. Now, this location of the cotton wool spot is important because if it is near the disc, you get all the changes that look like glaucoma. If it is away from the disc, it may not look exactly like glaucoma. So how do you identify that the changes that are looking exactly like glaucoma on OCT, are they due to cotton wool spots or are they due to glaucoma? Because most of our patients who have glaucoma also have hypertension, kidney disease, small cerebral vascular disease, and diabetes. All of these cause nerve fiber layer defects. So here is an example where you can see there is significant loss of nerve fiber layer. There is this arcuate loss here. But what you see is if you scroll through this retinal thickness, you realize that there is a spot out here in the periphery that there is a loss of the inner nuclear layer. If you see a focal spot of the inner nuclear layer loss, that is due to a vascular event. So you see these very wavy patterns in the middle of the retina. That's because of cotton wool spots. So if you see this, likelihood that what you're seeing is not glaucoma. Now here is a hemi-field loss, a hemi loss of the nerve fiber layer, a loss of the macular thickness, which is respecting the horizontal midline. Whenever you see a horizontal midline respecting disease, it is most likely a vascular event. Like this is a non-arteritic ischemic optic neuropathy. Then there is misinterpretation artifacts. You see the patient at one time, before and then after, and you realize there is a significant loss of macular thickness, significant loss of nerve fiber layer, but what you did not see is in between, there was a swelling of the nerve fiber layer, and that was again because of a vascular event. Now, this is a patient who has a superior arcuate defect, a arcuate loss on the macular thickness, a focal loss here in the RNFL thickness, and you can see the loss of the nerve fiber layer thickness. So it looks exactly like glaucoma, but it turns out to be a branch retinal artery occlusion. You can see that on the this red-free image. Now, these are just some unusual examples that are just being presented to highlight the importance of looking at the entire picture. Remember one rule, that in glaucoma, especially in the early stages, you should not see any abnormality in the temporal region. So when you have red disease in the temporal region, when the cup is not total, it indicates it is possibly neurologic. And so even though this looks like an arcuate pattern loss, there is a loss of nerve fiber layer, but it shouldn't affect the temporal segment at this stage. And this turned out to be neurosyphilis. So think neurological if you see a temporal loss. Now, what about this case? Are we dealing with severe glaucoma here? You can see the severe loss of nerve fiber layer in both eyes. But are you able to pick up a pattern? The pattern is right there. It's not very easy to identify what's going on when you look at the nerve fiber layer. But if you look at the macular thickness, you can see the vertical cut in the ganglion cell or the total macular thickness, so it's homonymous hemianopia. Or this one that tells you that a patient can have as many diseases as they like. This is a patient whose baseline nerve fiber layer thickness in the right eye seems to be getting thin, but thinning mainly in the temporal region. You can see that the difference between the baseline and the next macular thickness is loss again in the papillomacular bundle. And then you can see that the visual field is getting worse. This patient does have glaucoma, but the visual field is getting worse. How many of you are able to notice the pattern of bitemporal hemianopia in this? You can see there is a loss on the other side that's respecting the vertical midline, and on this side also. You don't get the textbook vertical midline picture always. And sure enough, it was a big pituitary tumor. How about this? You can see the nerve fiber layer thickness dropping tremendously, but that's because of vitreous traction that got released. As simple as that. And you can see it on a 3D image as well. Here is an example of a 42-year-old monocular patient who had lost the other eye due to an injury, who is on maximum medicines, comes in for a second opinion for normal tension glaucoma because he's been advised trabeculectomy. But wait, his field is normal. When you realize this, you see this pattern here. You see all these blood vessels coming out like the spokes of a wheel. This tells you that this is optic disc hypoplasia. This is optic nerve head hypoplasia. And the last couple of cases, whenever you see symmetry is not typical of glaucoma. And you can see that there is symmetrical loss in macular thickness, symmetrical loss in nerve fiber layer and field, and this is segmental disc hypoplasia. And this is an example of ghost macula. This, you can see there are cystic spaces. So patients who have severe sudden loss of ganglion cells due to very high pressure, especially if they are young and the vitreous has not separated from the retina does not get to collapse. So the macular thickness appears to be normal, but it's not really normal. You can see these cysts. These are not CME. These are vertical cysts. That is possibly because the vitreous is not allowing the retina to relax. And then catching OCT before thickness change. You can see that area, which pointed by the yellow, where there is already nerve fiber layer is hollow. Next visit, there is loss of thickness. So, in such a case, visual field may be affected already. And then you'll say, oh, but the OCT was normal, but actually it wasn't. So, thank you very much for your kind attention.
Thank you so much. That was a very enlightening talk. Yes, many times we do get patients who have been referred, treated for many years based on OCT only, and because of this red disease effect. So now we'll have the last talk by Professor Tanuj Dada. So he's a professor at Dr. R.P. Center, AIMS, New Delhi. So as always, we used to always wait for Sir's talks, because at that time we will have to wake up to listen to all the questions that Sir is going to put forward to us.
Thank you, Dr. Gazela. And this is supposed to be audience interaction. So I'll be asking you some questions, Gazela. Don't mind. The slides are not moving. Okay. So this is a vice chancellor of a university who comes into my OPD, pressures borderline CCT 530, and there are early visual field defects, and the patient has been for last 10 years on latanoprost. So this is a very common occurrence. You get a VIP in your OPD, borderline pressures, and this looks like a very excavated disc with a large cup disc ratio. And because of the fear of that personality, such patients are often started on therapy, and you can see this, some visual field defects are there. And that is where OCT comes into play, because there is a absolutely normal RNFL profile, and that tells you that there is a false positive visual field and just a borderline intraocular pressure. Such patients, you can stop the therapy, but keep the patients on a lifetime watch. Every year they have to come for follow-up and serial OCT. So that is the first primary use of OCT in the OPD, to rule out glaucoma in patients with a large physiological cup disc ratio, who are often labeled as glaucoma, because the amount of training in diagnosis is not adequate, and that is why the OCT comes in very handy for such patients. So we can stop the treatment confidently and ask the patient to review every 6 to 12 months, 6 months for those who have risk factors such as pseudoexfoliation or disc hemorrhages, or have any cardiovascular disease or diabetes. So this is another patient. So this was referred as a juvenile open angle glaucoma suspect, 22-year college student with apparently healthy disc and normal visual fields. And the question was whether he should be put on therapy or no. So maybe Gazela, would you like to comment on this? What does the clinical appearance look like?
So here the discs seem normal, sir.
Yeah. So this is, the patient was referred, and it was referred as patient has not been, there is no glaucoma, there is a healthy disc. And patient came to me for second opinion. So this is what happens. So in the OPD, we miss these patients. Visual fields nearly okay. And now you can see what is happening on the OCT. Left eye, there is a very significant dip in the retinal nerve fiber layer. So this is what we miss, the clinical examination, miss these RNFL defects. Now you can see this is the area of left eye, superior RNFL defect, very clear cut area is lost. And this was the appearance of the disc. Now when you go back and read the disc and see the retinal nerve fiber layer, compare the striations of the right eye with the striations of the left eye. Now here you can see this is the RNFL defect. So that is another use of OCT. If the OCT shows you an area where there is RNFL loss, you go back to your fundus photograph and see in detail. you must try to correlate the OCT with the fundus photograph, and now you can see maybe this area, this area, this area, this area is darker. So there is a clear-cut superior RNFL defect visible in this patient, normal fields, and so it is justified to diagnose the patient and start therapy because there is a well-defined structural defect. And there's one more very nice thing about the OCT. This is the spectralic OCT. You have a pseudo color map. So here, if clinically the RNFL defect is not visible on this green and blue reflectance, now you can see this was the right eye, but here very nicely this RNFL defect is visible. So before you go to the interpretation of the OCT map, always look at the pseudo multicolor image on the spectralis scan, because this is where you will pick up the RNFL defects. Even in myopic patient, this blue reflectance is very good. So here you can see clear cut, this is the RNFL defect visible, which was diagnosed on the OCT, missed on clinical examination because the disc appears very healthy. So this is another patient. So would you like to volunteer, our previous resident? So these are difficult cases, so no, don't worry about getting it wrong.
Yes, sir. So when we see in the
see this, the RNFL profile,
yes,
and this RNFL, this is normal or abnormal?
so that is normal.
Very good. So this is what happens. So this is looking like a absolutely normal, all the quadrants appear absolutely normal. Please sit down. So this was passed on as a normal OCT, and what I want to highlight a very important thing about the OCT, because rest of these scans are dependent on the age matched population. So you are comparing these with the normative database. There is only one scan where you are not comparing with the database. That is the most important scan, that is the thickness map. Now if you see, compare, there are two yellow streaks of the healthy RNFL, and see the streaks here. There is a blue streak running in between this yellow RNFL. So this is the area you have to watch out for. So this blue streak tells you that there is an area which may be RNFL defect, and this will not be picked up on any of the global scans on the OCT. But if you see the thickness profile, there is a dip here. You can see the right eye, there is a dip in the RNFL, though it is not reaching the abnormal curve for the normative population. So this is the left eye and this is the right eye, and this was the area of the RNFL defect. So this can be taken as what Dr. Asani showed you was red disease. So this can be taken as a green disease, because on a cursory examination, the OCT is appearing green, normal. But actually the patient has a RNFL defect. So this is other way around. OCT may be green, but there is actually glaucoma. And how you have to pick this up? Always see the thickness map. If there is something missing in the thickness map, such a focal area of defect, that points that there is a early damage to glaucoma, which is not coming up on these global parameters. So this was the RNFL defect, very nicely visible. This is a patient of early glaucoma. Now this is a very common referral. So this is a 51-year-old male. He's already on timolol. Baseline IOPs are 21, 22. Fields are within normal limit. So this is the most common referral we get, that you have to give a second opinion whether patient has glaucoma or doesn't have glaucoma. And this is where OCT is very helpful. Now, there is something specific I want to highlight about the OCT, which is normal variation. You get a bifid RNFL. So you can see this is a normal RNFL, what you usually see. But the superior RNFL is broken into two branches. So this is a physiological variation. Sometimes these patients can be labeled as abnormal because there is a dip here because of the physiological bifid nerve fiber layer. But this is absolutely healthy disc and absolutely normal retinal nerve fiber layer. So we could stop the treatment and ask the patient to be on follow-up. Now this is another case. So now the audience is, so just raise your hand. Is it normal? How many you feel it is normal? How many you feel glaucoma? So first let us go for normal. Are these two discs normal or no? So we have, very good. So how many feel that it is glaucomatous? So you can see now why OCT is useful. It's 50-50. Half are raising that it is normal and half are raising that it is normal. So the problem is that when we clinically see the optic disc in the OPD, we miss these findings. So it is always better to take a fundus photograph, and like the radiologist reads the MRI, that is how you should read a fundus photograph. Now see clearly what we have missed. You always look at these 4 regions of the RNFL, healthy RNFL, healthy RNFL, healthy RNFL, see this area. So this is a RNFL defect which you can easily miss in the OPD examination, and we had also missed, don't worry. And because this is a IAS Secretary Government of India, so he requires more attention, so he will go through a lot of investigations. Fields were also nearly normal. So he was diagnosed that you don't have glaucoma, you just come for a second opinion. And now this is the OCT. So you can see OD is normal, left eye, inferior RNFL defect. So now half of you were right, half of you were wrong based on the OCT. So again, I am telling you, if you see this OCT, it doesn't end here, you go back and now see. So this is the area which we missed in clinical examination, and that is why if OCT is showing you a defect, go back and see. Clinically, definitely this is correlating, there's an inferior RNFL defect. So we were clinically diagnosing this patient as a pre-perimetric glaucoma, and we had to start the patient on therapy because there is a well-defined structural damage occurring to the optic nerve. So this is another one of my colleague from AIMS and referred that you have glaucoma. And this happens, you can see there is a asymmetry of the cup. So if you have patients with asymmetric refractive error, you can get asymmetric cup and looks like what we have been taught traditionally, 0.2 or more cup-disc ratio difference glaucoma. And again, due to asymmetric refractive error, absolutely healthy RNFL, so no glaucoma. So again, from the audience, first poll, how many of you feel there is glaucoma? So I can see 2 hands for glaucoma. So that means most of you feel this is normal. So that is, and another thing is this patient has got absolutely normal intraocular pressure. So that was the clinical impression when this patient was referred, that he has got healthy discs. And again, I am telling you what is very important to see on the fundus photograph, read it very carefully. Focus on these 4 regions. There's a white streaks here, white streaks here, white here. If you compare, there appears to be some loss of these white striations. So concentrate on the right eye. So you can see here, clearly there is an inferior RNFL defect, loss of the inferior retinal nerve fiber layer, clinically not visible, and as you can see from the audience poll, you said this is normal. And many of these hypertensive patients are on systemic beta blockers, so the intraocular pressure may be normal. So based on the OCT, there is an inferior RNFL defect, and patient was clearly diagnosed as glaucoma and started on therapy. This is another very interesting case. So typically referred as a case of juvenile open-angle glaucoma, and patient already was on Travertin, because you know when you see this young person with such an excavated optic nerve head cupping, so it comes into mind this is glaucomatous. And that is where OCT is very helpful. So clearly just a large disc with a large cup-disc ratio, which is totally physiological with a healthy RNFL, so you can rule out glaucoma. Now this becomes slightly difficult because this is a fellow ophthalmologist. So now the stakes are very high. So again from the audience, that is appear normal. How many would you raise a hand for normal? So we have 5 hands for normal. So I think many of you are in that nota category. Neither yes, neither no. So this is now very difficult to diagnose. So this looks quite normal. And there was a very subtle RNFL defect between these two blood vessels. And you can see this area which is showing you RNFL defect. So no way you could have diagnosed clinically this patient, fields are normal, and he's a fellow ophthalmologist. And there's a clear-cut RNFL defect. And when you see the fundus photograph, this is the area where this RNFL defect is occurring between these two blood vessels. So patient had a structural damage, and we could diagnose as glaucoma. And maybe the time is now running out. So this is a 16-year-old patient. This is the optic disc. And this is the OCT. So what do you feel, glaucomatous or no? How many of you feel it is glaucomatous? And how many of you feel it is normal? So this is the disc photograph, and OCT is absolutely outside normal limits. So this patient, 15 years or 16, the database is 18 years. So what the operator did, he applied the 18-year-old database to this 15-year-old child. So whenever you have children or patients who are outside the normative database of the machine, you cannot rely on the OCT. So this OCT is showing absolutely that patient is abnormal, but patient is absolutely healthy with an absolutely normal visual field. So this is red disease, false positive. So I think I'll stop here. So you can see how to use the OCT in your OPD. You always do the OCT and then go back and study the fundus picture in detail, and then you will arrive at a diagnosis in a lot of patients which you have clinically missing in the OPD. So thank you very much for your kind attention.
Thank you, Dr. Tanuj. As usual, the interesting talk and a lot of things to learn. And now we have 7 minutes with us. So any questions from the audience? Yes, sir.
Dr. Dada, I loved your talk. I have a question about, sometimes we see these defects on the nerve fiber layer or in a quadrant, and sometimes we can see it on the photo as well, but how often do you just watch them and see if they become larger? Do you always need to treat just because you see these defects? Because sometimes we just see those, and I just kind of watch them sometimes.
So I think Steve has raised a very important point. So I think there are two scenarios. If the patient is hypertensive or diabetics, in many occasions you can get these defects due to the vascular cause, and they will be static. If you have a patient who has no other risk factor or has a family issue of glaucoma or has a slightly higher pressure and has an RNFL defect, then second thing you do is you do the ganglion cell imaging. If there is a corresponding loss of the ganglion cell and there is a RNFL defect, then you have to have a discussion with the patient. If he can come for a follow-up, say every 4 to 6 months, then we can leave the patient, wait and watch. But if you discuss with the patient, he cannot come for follow-up and he is very anxious about his disease, then in those patients you may be justified in starting therapy. But I totally agree with you. Many of these defects we have been following up have not progressed in patients who are hypertensive or smokers. So there can be non-glaucomatous causes of these RNFL defects.
Any other questions from the audience? And I have to make one comment about OCT, which I make quite often, that whenever you are taking OCT as your criteria in the management of glaucoma, then you must make sure that the same machine is being used every time for the OCT, because the technology is different and the measurements are different. Even the macular area study, if you know, the different machines have got different layers which are included in the various measurement. So those factors can be negated if you take every time OCT or whatever, even on the same machine at the same location. And Dr. Sanjay Asrani's talk was really fantastic. And now I know probably the audience can start diagnosing more neurological cases on OCT rather than glaucoma.
That is always the thing that we worry about, that are we really treating it, is it glaucoma? And that's why Dr. Mansberger's question was very apt, that are these nerve fiber layer defects coming from glaucoma, or are they coming from, as Dr. Dada said, possibly hypertensive, diabetic, or kidney disease? They seem to have a lot of nerve fiber layer defects. So one has to watch them carefully, because it is not easy to differentiate. It is only if you're very lucky, you'll find the small area where the cotton wool spot had occurred. So we have to make sure, first of all, there is no neurological condition, because those are life-threatening.
And Dr. Deepak, what the perimetry that he showed on the follow-up, then if you see the overview printout, in that there is a catch. Because if you see only the p-value, say the dark circle, after certain, say suppose in particular area, after say 6 decibel the dark circle appears, dark square appears, it means the significance is p-value is less than 0.5. After that, even if there is deterioration in that area, it will show the similar pattern. So then it loses its sensitivity in the vertical direction loss, but of course lateral, if there is something new area appearing, then you will pick up, but not the vertical in that. So that you have to be careful if you are analyzing the overview printout.
I was just wondering how many people would like to, despite the machine telling you and the manufacturers telling you not to dilate, and that in a small pupil you can do an OCT, how many people would like to dilate, and if so, why?
Means from the speakers first?
And the speakers, I would definitely love to get an answer.
Actually, in our practice, once we are ruling out glaucoma, we don't dilate. We do a fast RNFL scan. If that is completely normal, it's fine. If there is an abnormality, then you have to dilate and do a full scan, macula, everything. That requires dilatation.
So obviously, when you have got a huge OPD, then you would prefer to dilate, and the patient is dilated, then you just go ahead and do the entire scan. I think that gives a lot more information also. So what you were saying, of course, Dr. Dada, is fantastic, but yes. There was one more thing, in the CETA faster, Dr. Edwards, sir, our optometrist, she raised a question. She said that there are too many repeats, the patient is not able to do it. And we realized that when you do the CETA faster, it is so fast, that most patients are not being able to make out that this is the target. What is your experience, sir?
Our experience has been different. The patients have been typically, that's not been our experience, other than you have some really elderly patients, or they have some cognitive disabilities. They may have some trouble with it. Or some that have been used to doing a CETA standard for a long, long time. You present something new and the technician doesn't explain what the new test is all about, they can have some trouble. But generally the patients have, especially the ones that are in the 50 to 70 age group, they enjoy having a shorter time at the visual field machine. Yeah.
But do you think you are losing out certain informations?
Yeah, you might lose some information. So like I said, I think this is not a good test for very severe glaucoma. You miss things out in there. I think for early to moderate glaucoma, it's pretty good. And yeah. And I think having the central points in the C2 are certainly helpful to pick those points out which you might have lost when you were doing your regular visual field tests. Yeah.
So 24-2C, which are the patients who you actually advise, like all the suspects, or?
Yeah, we now routinely use the C2 for that. And again, as you all know, there's a glaucoma audience. There are artifacts, there are learning curves to it. So I think the correlation with the clinical exam and if the OCT is important. But I think when they have those defects, I usually ask patients about symptoms, and you can elicit those symptoms about reading difficulties and, scotomas get magnified in the distance. So issues that patients will notice, and they think it's part of aging, and they don't complain about it. And patients will tell you how they avoid it and avoid the scotomas in different conditions. So we've switched over. I think the 3 or 4 of us are in the department. We've decided to switch over to the C2, and we're doing that for all the patients now. So I don't know what your practices are. You can comment on that.
I was wondering if Steve has a comment. He was just about to come.
I was just going to say that, well, I can comment first about the dilation, is that at least with us, if we don't feel like they've got a good dilated exam in the past, then we do that just to make sure we don't pick up something else that we wouldn't see on OCT image. It's just kind of embarrassing, if they do go see somebody and then there's a big hemorrhage on the peripheral retina or something that you missed. As far as the CETA faster, I think the studies show that it is more variable just because it crosses the seeing to non-seeing threshold just once versus CETA standard, which is twice. And so you'll see defects that come and go with the CETA 2. And so, one thing that, that Dr. Edwards mentioned, you just have to repeat the visual field if it looks abnormal, because on repeating the visual field, a lot of times these will become normal. I think that's out of time.
That's our time. And coming back again to the Sagrika's, Dr. Sagrika's question, I prefer to dilate for doing OCT.
I also do that. It gives me a lot more information because I can pick up everything. I mean, the macula and the RNFL and the ONH, everything. So that is additional information, yes.
So thank you very much, all the speakers, the chairpersons, and the audience, because without audience, we are nowhere. So I'm really thankful, and it was a useful session. There is no doubt about it. Thank you very much.